Welcome to this module on radiological anatomy of the upper limb. This module will cover normal and abnormal radiological images of the upper limb. Let us start with a normal X-ray of the shoulder joint. This example is an AP view or an antero-posterior view. As mentioned in the previous module, we must first assess whether the complete joint is included in the image. In this particular example, we see the medial end of the clavicle, the midshaft, and the lateral end of the clavicle here. The lateral end of the clavicle articulates with the acromion process of the scapula to form the acromioclavicular or AC joint. Inferiorly, we see the glenoid of the scapula, which extends from the body of the scapula, and here is the coracoid process. The glenoid articulates with the head of the humerus, which is attached to the lesser and greater tuberosity of the humerus that extends down into the shaft. Whenever we look at X-rays, one must make note of the position of the patient. In this particular instance, the shoulder is in external rotation. Compare this with another view of the shoulder, also an AP view, but in internal rotation. In this case, the head of the humerus has a different profile, and the greater and lesser tuberosity are not clearly visible. One can also have an axial view of the shoulder joint, such as this. In this particular instance, the shoulder is in abduction, and the X-ray tube is placed in the axilla of the patient, and the X-ray film over the shoulder. Here we see the glenoid articulating with the head of the humerus. The scapula is seen here with the acromion process, and the coracoid is seen here, which points anteriorly. Let us now look at a MRI or magnetic resonance imaging scan of the shoulder. This is the right shoulder joint, and it is a coronal view. Note the excellent visualization of multiple types of soft tissues. We can also see the bony structures such as the humerus and the acromion. One can also see the fat and skin, as well as different types of muscles such as the deltoid muscle seen here. The structure demarcated L seen here is the glenoid labrum, which is a fibrocartilaginous structure at the edges of the glenoid cavity that deepens the socket and provides extra stability to the shoulder joint. CT scans are also used for visualization of the upper limb structures. Here we see two examples of 3D views of CT scan reconstructions that depict the upper end of the humerus on the left side and the scapula on the right side. Let us look at our first upper limb clinical case. We are presented with a 24-year-old male who sustained a direct injury on the right shoulder joint while playing football. An X-ray of the shoulder joint was taken, and it's shown here. Note the acromioclavicular joint has been separated. The lateral end of the clavicle lies superiorly as compared to the acromion process. This is an acromioclavicular dislocation. All joint disruptions can be classified as a subluxation or a dislocation. A subluxation is defined as an incomplete loss of contact between the articular surfaces. In this example, the articular surfaces here, which make up this particular joint of the finger, are partially opposed. In a dislocation, there is a complete loss of contact between the articular surfaces. This X-ray here of the elbow joint shows the articular surface of the proximal ulna completely out of its anatomical position and articulating with the distal humerus. Our next case is that of a 9-year-old child who sustained a direct injury on the shoulder joint while playing. X-ray is shown here. Note the proximal end of the humerus has a fracture. This fracture is of a special type and is closely associated with the epiphyseal plate or the growth plate that is seen here. These epiphyseal injuries occur only in children that have open epiphyseal plates or growth plates. They are of multiple types and classified based on the Salter-Harris classification. In this instance, this is a type 2 Salter-Harris fracture. It is not important at this stage for you to know the different types of epiphyseal fractures, but suffice it to know that there are multiple types that have different significance with respect to growth disruptions. This clinical case is of an 11-year-old child who complained of history of chronic pain in the left arm for 6 months. The child complained of a sudden increase in this pain for the last 1 day. The X-ray of the left arm of this child is shown here. Note that the growth plate is still open and there is a enlarged swelling and cystic changes in the proximal part of the humerus. There is also a fracture through the shaft. This underlying pathology here is that of a simple bone cyst, and a fracture through the cyst will be termed a pathological fracture. Any fracture that occurs through a bone that has an underlying pathology pre-existing is called a pathological fracture. Our next clinical case is of a 36-year-old female who was involved in a motor vehicle accident and injured her left arm. This is the X-ray of the humerus, which shows a fracture over the mid-third and distal third of the humerus. It is a comminuted fracture because it is in more than 2 parts. A fracture of the shaft of the humerus. In such instances, we always correlate the anatomy, the pathology, and the radiology. There are certain important neurovascular structures that course through the limb in close proximity to the bone. At this particular juncture, we have the radial nerve, and we should always look for radial nerve injuries clinically prior to any treatment that is given to this patient. Our next clinical case is of an 8-year-old child who fell from a swing while playing and injured her elbow. The X-ray of this child's elbow is shown here. Note a fracture occurring through the distal part of the humerus. There is also a rotation of the distal part of the humerus as compared to the proximal shaft. This is termed a supracondylar fracture of the humerus. In such cases, one always observes for important neurovascular injuries. The beak of bone, which extends at this point, is in very close proximity to the brachial artery, and one must always rule out any brachial artery injury at the time of diagnosis. The next clinical case is of a 44-year-old male who sustained fracture of the radius and ulna 2 years ago. The patient was treated and now presents to the clinic with complaints of deformity at the original fracture site. This is the X-ray of this gentleman. The radius and ulnar have united, but have united with angulation and have also united to each other. This is a case of malunion of the radius and ulna. There is also cross union between the two bones. Such type of deformities have a cosmetic as well as a functional implication. Our next clinical case is of a 68-year-old female who slept. This case is of an 8-year-old child who fell from a swing while playing and injured her elbow. The X-ray of her elbow is shown here. One can note in the distal humerus there is a fracture that crosses through the humerus bone above the condyles. The condyles of the humerus seen here are rotated as compared to the proximal shaft. This is called a supracondylar fracture of the humerus. In all cases of fractures, one looks for associated neurovascular injuries. When one sees an X-ray such as this with a prominent beak or sharp end of the bone, one must look for the associated nerve or vessel injuries that are anatomically close to it. In this particular instance, one should look for brachial artery injury. The next case is of a 44-year-old male who sustained a fracture of the radius and ulna 2 years ago and went through lengthy treatments elsewhere. The patient presented to our clinic with the complaints of deformity at the original fracture site and restricted movements. The X-ray of this patient's forearm is shown here. Note the radius and ulna have united, but have united with an angulation. They have also united to each other, and the whole fracture site is enveloped in a one callus. This is a malunion of the radius and ulna associated with a cross union between the radius and ulna. Such a deformity would result in restricted movements, particularly of pronation and supination. Our next clinical case is of a 68-year-old female who slipped and fell on the outstretched arm. Her X-ray is shown here, and she has sustained an injury to the distal radius or the wrist region. The deformity that occurs at the distal end of the radius is typically called a dinner fork deformity, and this is a common fracture called Colles fracture. This case is of a 38-year-old male who sustained a direct blow on the thumb while working at a construction site. The X-ray of this person's hand is shown here, and note the fracture that is seen at the base of the first metacarpal. The fracture line is running across here, and there is also an associated dislocation of the first carpometacarpal joint. This particular fracture goes by the name of Bennett's fracture dislocation of the first CMC joint. Here's a pop quiz. No history available. What is the abnormality? The answer is congenital absence of thumb. Simple and straightforward. Always remember to look at all parts of the X-ray, and the first principle is your entire anatomical part included or not? Thank you very much. This brings us to the end of this module on radiological anatomy of the upper limb.